One blast off. I didn't do it right this time. Hi, this is Elliot Fishman. Welcome to our CTisus quiz. It's 5/16/2024. Hope everyone's doing well. Lily was just showing me how Facebook, again, for the 1,000th time, has changed how you get into Facebook Live. So hopefully we're here, we're live, and we're doing well. I have 10 cases for you, so let's go through them. And what I did is I made them all stomach cases, so it's really nice and easy. Case number 1, 75-year-old female, nausea and vomiting. What do you see? Diffuse gastric wall thickening. Could it be gastric cancer? That's a possibility. It's low density. Could it be gastritis, severe gastritis with inflammation? I don't see perforation. I don't see discrete ulcer, but I see lots of edematous folds. And this was indeed gastritis. It was infectious gastritis. The comment is that at times it's difficult to distinguish tumor from inflammation. Tumor is usually more diffusely infiltrating solid. Edema is more likely with gastritis, though that's not always the case. Tumors can be necrotic. Ulcerations can happen in both malignancies and inflammatory conditions. And again, endoscopy is how you would evaluate the patient further. A very important point is technical in this case. You got to distend the stomach with water. If you don't distend the stomach, then you could overcall the presence of thickening or undercall the presence of thickening because you're not really certain. So protocol is everything. Case 2, acute abdominal pain. And now you're looking at the antrum of the stomach, which is thickened. So maybe it's gastric cancer, maybe it's gastritis. I don't see a perforation, I don't see an ulceration. But if I looked harder, perhaps I would have seen that ulceration right there. I thought it was a little bright. I was worrying that that was a tumor. It was a small ulceration. Ulcerations are difficult to define on CT, and surely distinguishing malignant from benign ulceration is often impossible unless you see signs that definitely tell you you're dealing with a malignancy. You can look for free air. Perforations can occur from ulcerations, but that's true with malignant and benign. Again, the importance of stomach wall thickening, the importance of the good distension of the stomach, and again, we talk about eccentric focal thickening is abnormal. Yes, it could be tumor, but it can be, as in this case, inflammation. So very, very nice example. Another case, here you see pneumoperitoneum in this patient with abdominal pain. You also see an ulceration with perforation. The stomach is really thickened. I would tend to favor a malignant ulcer rather than a benign ulcer, but again, you'll get endoscopy and biopsy because even the endoscopist can't be certain. And this indeed was a nice perforated gastric ulcer. In this case, it was inflammatory, not neoplastic. And again, complications of perforations can be fistulization, pneumoperitoneum. And again, patients often present with acute abdomen. When we see pneumoperitoneum, you're thinking about gastric perforation, duodenal perforation, as well as perforation of the patient's colon, particularly the patient's sigmoid colon. Okay, another patient with abdominal pain. You look at this case and you say, where is the stomach going? Okay, you see the esophagus, you see the duodenum. Where is the stomach here? It looks like it's twisted, and that indeed is the case. I think gastric volvuluses are tricky. I think truthfully all volvuluses are tricky. You know, cecal and right colon and sigmoid volvulus. At times you see distended colon. You're not really sure what you're dealing with. With organoaxial gastric volvulus, rotation is around the gastric long axis. Severe abdominal pain, retching. You can't pass an NG tube because it's twisted on itself. CT findings include reversal of the positioning of the greater and lesser curvatures, as you can see in this case, that paraesophageal hernia, and again, ischemia can develop late with pneumatosis even in the gastric wall. It's a surgical emergency, but it can be tricky. Another case, here we see the stomach, and it looks like it's twisted, right? by the D here. Okay, that's a duodenum. The stomach looks like it's, that's a duodenum. Stomach, but stomach above and below the diaphragm kind of looks like a dumbbell configuration. You got to worry about volvulus here, and this was a mesenteroaxial volvulus, which is rotation around the short axis of the stomach. It's less common than the organoaxial volvulus. Again, you know something's going on. The stomach is really distended, the bowel is collapsed. We don't, any of us, we don't see a lot of gastric volvulus, and so you may not be thinking about it. I think in these cases, coronal views, routine look at coronal, is very helpful, but it can be somewhat challenging, and again, these are surgical emergencies. Another case, acute nausea and vomiting, and you're getting the point here. We're looking at acute gastric pathology. There is pneumatosis in the gastric wall. That's ischemia. It could be from ulceration, could be from poor flow, are all possibilities. Gastric pneumatosis can also be benign, but most of the time you're thinking like small bowel. Infection ischemia can be iatrogenic, can be ingested matter. Stomach, particularly if someone drinks like Drano or something from under the sink, can be very, very potent in terms of giving ulcerations, mucosal erosions, and gastric pneumatosis. Again, management will vary depending specifically on the cause. Another patient, nausea and vomiting, and it looks like something's in the antrum pushing toward the duodenum. It could be a mass, could be a polyp causing a form of intussusception. Remember, things in the antrum can herniate down into duodenum. Things in duodenum can herniate back up into the patient's stomach. And this was indeed an intussusception. Can be due to polyps, can be due to malignancy, like a mass like a lipoma. This was a hyperplastic polyp. It kind of looks like a swirl sign, right? You don't see the diffuse infiltration and invasion you might suspect to see with malignancy, but we do have the gastric outlet obstruction, and we do have this spiral thing, a majig, which is the intussusception. Again, surgical management, it is a surgical emergency. Another case, acute abdomen following MVA. Now, we think about liver, spleen, adrenal, kidney. You don't really think about stomach. We know you can get bowel injury. We mainly think about the duodenum. But here, we're looking at the stomach and what's going on in the stomach. That's the question. And what you're dealing with is a mural hematoma, okay? Again, the stomach is distended. I thought maybe it was a bleed, which indeed this is. Mural hematomas from trauma are exceedingly rare. Remember, liver, spleen, kidney, adrenal, all the usual stuff. Bowel is fairly uncommon, more common maybe in a penetrating wound from stab or gunshot. You can get bowel from seatbelt injuries. We talk about duodenal injury, but stomach is fairly rare. You can get penetrating injuries to the stomach with pneumoperitoneum. You can get hemorrhage. Again, this is typically a surgical emergency. Just a really nice example. Now, this patient had bad breath. Well, you can see the stomach and you can see positive contrast going into the colon. So the patient had a gastric colic fistula. One of the things we've commented on before is when do you use positive contrast in the stomach? Well, I think if you can't give IV, positive is very good. I think if you're looking for fistula, it's great. Fistula is the best seen with positive contrast material. And so in this case, we gave some positive contrast. You could see it layering out in the stomach, and then you see the connection between stomach and colon, the so-called gastric colic fistula. Again, fecal vomiting, halitosis, undigested food in the stool. It can be due to perforation, can be due to injury, can be due to penetrating ulcers, which was the cause, I believe, in this case. Again, it's easy to miss because you have inflammation. Things are typically abutting each other, but it's something to think about. And again, if you're thinking about the possibility of a fistula, please give positive contrast material. Okay, number 10, acute nausea following initiation of prednisone. Look at the antrum, look how thickened it is. And again, a good example of gastritis. Now you can have gastritis from medication, from eating certain foods. There's many, many reasons. Again, wall thickening can be focal or diffuse. One of the challenges when gastritis is focal is distinguishing gastritis from gastric cancer. Again, can be challenging. I think for us in radiology, the key thing really more than anything is finding the presence of gastric pathology so you know they can do endoscopy. So I think it's a matter of getting our act together to really help them out. So again, you do endoscopy, you're looking for neoplasm. In this case, it was chemical gastritis. 2 more. Cirrhosis, anemia. You see high density fluid in the stomach. Yes, you could have drinking some Maalox, but that's even higher. When you see high density fluid in the stomach like this, that means there's a bleed present. Now, you're not always going to see an active bleed. Sometimes you will see an active bleed, and I've shown cases of that. Sometimes you're just going to say, well, I don't see an active bleed, but I see blood in the patient's stomach, which is a very nice example. Whether it's an ulcer or a varix, Mallory Weiss, a vascular lesion like a carcinoid, or other neoplasms. Again, you want to look carefully for active bleeding. You want to see, is it bleed from a tumor? Is it from an ulcer? What exactly is going on? And again, depending on the patient's condition, endoscopy may be the next stop. Now, I think if you don't see GI bleeding, usually you can wait. Endoscopy becomes more of an elective in that case. If you see active bleeding from a varix or from a ulcer, then you're going to bring the endoscopist in the middle of the night. Okay, one last case. 2 patients with anxiety disorders. You can see both on the left and on the right. There's some opaque density in the patient's stomach. Patients at times, particularly patients with mental challenges, can swallow things. Now, you can be, you could swallow things. Kids swallow coins. People have something in their mouth and they swallow by accident. But these are both foreign bodies. One was a toothbrush and one was a Christmas light. So always think when things have shape that perhaps it's a foreign body and it's not simply going to be something that should be there. Okay, and these will be removed typically by endoscopy. Again, they can lead to perforation, ulceration, and bleeding. So really nice example. So with that, I've shown you a dozen cases of acute gastric pathologies. I do have a talk we posted within the last couple of months on acute gastric pathology. You should listen to that. We have a number of other talks of the stomach. You should listen to that. And with that, I'm going to wish everybody a great day. And unfortunately, when I show the quiz, I can't see any comments anybody made. So if you're from the Sudan or Egypt or Israel or Baltimore or New York or any place in between, Ghana, Australia, any place you are, I hope you have a great day and I hope everything's okay, and see you soon.